Welcome, everyone. My name is Dr. Eliana Ramirez. I am the director of the Crisis and Recovery Enhancement CARE TA Center. I am honored and delighted and overjoyed to introduce to you Vanessa Jackson, who is presenting today a very exciting presentation from the CARE conference. Want to start off by just giving a disclaimer that we are funded by the California Department of Healthcare Services, and I work at the Center for Applied Research Solutions, otherwise known as CARS. While we are funded by and receive organizational support for this presentation, what we are about to say does not necessarily represent the opinions of anyone besides ourselves, but we do hope that you will engage us in critically analytic thought. We do not anticipate that there should be any challenges with technology or anything else, but in the event of a security issue, we would immediately close this room and then send an email with follow-up instructions about a new place to join in. Next slide, please. It's always important to start from a trauma-informed perspective, which involves talking about how we show up in community with one another. Our language matters. What we put into the chat box, what we raise in questions to one another, we want to use person-first language. So we refer to people as who they are first, a person who's living with a disability or a person who has a lived experience rather than a schizophrenic, rather than any number of other terms that people use to define someone by a mental health challenge. It's really important that we speak from our own experience. So we use I statements and we avoid making statements that speak for anyone besides ourselves. If at any point you feel activated by the very, very intense and difficult content that Vanessa is about to share, which is a part of our shared history, and you would like to speak to someone, please know that your experience of distress is completely normal and should be expected when we are exposed to very intense history and contemporary information about racism. Should you like to reach out to someone, we have the National Suicide Crisis Line. There's also a crisis text line, and importantly, a NAMI helpline and an LGBT national hotline. Please do write down these numbers and feel free to reach out if it would be helpful to chat with somebody. We'll go to the next slide, please. Without further ado, I would like to introduce the amazing Vanessa Jackson, who comes to us from a wide variety of expertise and experiences. And thank you so much, Vanessa, for being here.
Oh, thank you so much. And one thing that I want to just acknowledge, Tina and I share, we're both WashU graduates, and I can tell you, I so wish we had been there at the same time. I'm not sure that they could have handled it, but I'm so glad to know you and know that you are part of that community with me. I am so grateful to be here today because it gives me a chance to talk about some research and its application that's very dear to my heart as a social worker. I am, again, Vanessa Jackson. I am a social worker by training, currently living as a soul doula. And what I describe that as is helping people give birth to themselves. Because in a world where we are oftentimes mashed into things and experiences and labels that are not who we believe ourselves to be, it sometimes takes a lot of work to sort of unpack that and be one's authentic self. The other thing that I do is, although I'm shifting out, is I have been a psychotherapist in practice for 30 years. And am shifting to more of a coaching model, partly to bring more joy into my own life, but also to meet people and to think more expansively than I feel like sometimes I'm allowed to do within a clinical setting. And then my last passion is, and so it's my favorite thing, which is in doing genealogical research and other spiritual exploration, is I found out that my great-great-grandparents were root workers. And so in some ways, the topic of this, and that in honor of them, Claire Bourne and Martha Jane Kemp Dudley, I have a apothecary of aromatherapy sprays called Dudley's Apothecary. Why they're important is it speaks to something that we were talking about earlier, was about the in community healers that don't always get acknowledged. And so really want people to begin to think more broadly about what what healing looks like. And so I am just coming here, staying on the shoulders of all those people who cleared a path for me to be here and to talk about root work, both in terms of honoring the root work that they did as formerly enslaved people, brilliant creative folks that made a way for themselves and their descendants, but also root work about getting to the radical roots, the core of how we got here today, especially as it applies to mental health. So in that spirit, the learning objectives is to be able to identify at least one current day mental health practice or policy which contributes to racial disparities with roots in historical mental health practices. And so I do, when you're doing this, if you're going along and hearing this, I hope that it will invite you to go deeper, deeper, deeper. I believe that my In Our Own Voices monograph is available as well as Separate Unequal. And I hope that you not only listen to what those things are talking about, but find your own place to explore other histories. I'm looking specifically through an African American lens, but there are so many other communities that have been marginalized and have important histories that need to be excavated and explored as well. And that as we all come together with some joined roots, I think that we can build a healthier system that will not be grounded in oppression, as is our current system. The second learning objective is to talk about the seven healing questions. And that was something that really is a co-creation and a beautiful example of cross-cultural collaboration that can be applied to individual and organizational anti-racist inquiry. And then to think about one concrete action that utilizes the historical information shared in this workshop and resource materials for application to a personal and professional anti-racism action plan. And one of the things that's really important, I know not only for myself, but for the organizers of this conference, is that we make this information have meaning, that we use it to transform. And so I hope that you will be thinking as you listen about what can I do with that? Some of it's going deeper, but some of it always has to translate into some observable action that can help change people's lives. So the power of history. How did a social worker get so deeply involved in history so that I would spend like a lot of my limited funds and like the last 20 years of my life delving into it? And I saw this quote that really stuck for me, is that if you believe people have no history worth mentioning, it's easy to believe that they have no humanity worth defending. And I think in our current uproar around critical race theory, which is actually just called actual history, truth be told, is that when we obscure people's histories and our role in their oppression, then it's very easy for us to continue to replicate those acts of violence on many fronts. So history is important because we need to understand how things got the way they are. And that begins to help us see, how do we turn them around? How do we go down literally to the roots again to transform these systems? A little bit more about my introduction is I was just working at a mental health association when Pat Deegan invited me to be part of a history project. And I had never done history research, had never done in some ways major writing at that point. And I just started following leads. And so that led me into something that basically has really transformed my life, made me really seriously question whether I could continue as a therapist when I found out the origins of my profession. And I'm glad that I found a path through that. But I think it was a question that I needed to grapple with as we start to understand how things became the way they were, and that it isn't just something that sprung up out of a whole series of evidence-based practices, but there was a whole lot of things that happened to get us to the place where we are with our mental health system. And I think there's a whole lot of transformation needs to happen so it can be rendered safe for more people. All right, this first slide was a picture that I took at Central State Lunatic Asylum, Central State Hospital in Petersburg, Virginia, which was the first segregated hospital set up for the colored insane. And it was part of the legacy of the Freedmen's Bureau. It started as a general sort of hospital. And I say started as a hospital, it really was people in a field in tents pretty much. And what became really clear is there was a lot of people who had mental health distress. And so there was the commitment to create a separate permanent facility for African American people who are experiencing some form of mental illness. I want to point out that that sounds very nice, but if you think about this, this is the state of Virginia that just got whipped, and that was broke in many ways. And what they chose to prioritize was creating a separate lunatic asylum for African American people, mostly because they did not want to have Black people in the same place as white folks. And so when we think about the very beginnings of for African American people, that it came out of, built into the bones of it, literally, was white supremacy. And so the decision was to take money and create this separate place. Now that makes it sound like it was a lot nicer than it was. Not so much. Always, and continued probably to this day, based on geography, is the underinvestment in mental health services in communities of color, specifically African American community, but I think it's very much true of other communities of color as well. What you see in this entry form, this is a notation in the actual logbook. And when I went to do my research at Central State Hospital, the secretary of the hospital said, "You got to see this, you got to see this." And she takes me into this room and she opens up this logbook from 1868. So it's a very delicate thing. And she goes, "You got to look at the entry number 13. And I just know that number. And it's Godfrey Goffney, who was 27, admitted in December 5th, 1868. Form of lunacy was homicidal-mania. Supposed cause of lunacy was freedom. And he was discharged, 18 years later as quote unquote restored. And when I went and found some other information about Mr. Goffney, what I found out was the thing that the homicidal mania was wants to kill every white person that he sees. Now, again, let's think back to 1868 and what was happening for Black folks there, Reconstruction, full swing. And that someone who might be trying to assert his dignity, his right to show up, really walk the streets, that somehow could end up incarcerated for 18 years. And we don't know the sort of treatment that he received necessarily and what was constituting restored. But again, this one document speaks to so much, like literally like freedom would cause lunacy. And there's a longer history about how people, Black folks, get pathologized for trying to assert their humanity. And this is a very early example of that. This picture right here is part of 2,000 photos taken by the superintendent of Cherry State Hospital, the Negro Asylum in Goldsboro, North Carolina. Hopefully the full set of pictures are going to be available soon. So with the hope that descendants can find their family members. But the superintendent took all these pictures, and this is from roughly, he was taken between like 1916 to 1926 or something. And so this is a group of people who are being leased out in effect. There was actually a budget item in the annual report that talked about the money that the state received, that the facility received for leasing out patients. So someone who was determined that they could not be home, they could not be working in their own communities, they could not be with their families, but who could be incarcerated in a psych hospital and leased out to other people. Now, this is beyond the work that they were doing for the actual hospital itself. And this is also true for many white patients in white hospitals as well. But I think especially evident in the 8 segregated facilities for African Americans is that the bulk of the work to make these things run was done by free labor. And not that people agreed to do this labor, although there was also sometimes sort of couched in the idea of occupational therapy, but that people are going out picking cotton, very hard manual labor. I talked to a family that interviewed that the caregiver for their children, and this was in fact an African American family, because again, it was very common practice to basically give patients to work for staff in these facilities. And so their caregiver for their children was a person who was a resident. And I just remember asking, like, there's just nothing that's more important and, difficult and requires so much trust and to give someone's the care of your children. And if he could do that for you, why couldn't he go home? And so over and over again, it's like we just get oblivious to the decisions that are made without questioning that. Now, one thing I'd also say is the power that Black staff had in those facilities was different. It was clearly power relative to the patients, but there was huge lack of power among African American staff as well. And so that was one of the complexities of doing this research. But again, the thought that you could go in to be in distress, not be able to go home, but then capable of going out and looking for other people is something we really need to think about. And we also need to think about in terms of our current day supportive employment programs, where it's like any job is worth getting you out there, and to say, really, is that truth? Are we also participating even in some of those programs and the exploitation of people's labor? So again, want to make that little note there, because to think about as we start to evaluate our practices, are there any residual sort of oppressive things built into the fiber of some of our practices and policies? This is a picture of the courtyard also at Cherry State Hospital, where people were just warehoused. I mean, and again, in this group of 2,000 pictures, there's all sorts of, just stories that are told about, like, people were not getting treatment. They were just being warehoused. I was saying earlier that my entry into this, I went from a social worker to a lay historian pretty quickly. And it all started with this one word, which I think is pronounced drapetomania. That's how I did it. The disease causing Negroes to run away. And this was Samuel L. Cartwright, who's a physician and pro-slavery activist. I will say I'm not sure how much, because that was a tight-knit group of psychiatrists. He was not part of that brotherhood that was the founding of the American Psychiatric Association. But he actually wrote about this in something called DeBow's Review, which was a farm magazine. But I think the idea of it is really, really important, and it showed up in policy and practices, including the 1840 census. But it's basically a condition unknown to medical authorities, but is well known to planners and overseers. And zoonotic disease not heretofore classed among the long list of maladies that man is subject to. It was necessary to have a new term to express it. The cause in most cases that induces the Negro to run away from service is as much a disease of the mind as any other species of mental alienation, and more curable as a general rule. Now, with the advantage of proper medical advice strictly followed, this troublesome practice that many Negroes have of running away can be almost entirely prevented, although the slaves be located in the borders of a free state or within a stone's throw of the abolitionists. Now, this treatment that they're referring to is actually with. And so, again, the thought that people trying to fight for their dignity, fight for their liberty, that somehow they were mentally ill. And I ask people sometimes to think about what are some modern day sort of parallels to this. And I think there's a number of them, but the one that immediately comes to mind are things like conduct disorder and oppositional defiant disorder, which we describe as sort of these diagnoses that also ends up with a lot of, especially African-American young kids, being caught up in systems, are ways of people trying to express their outrage. And yet it gets classified as a mental illness and gets treated as such, and oftentimes, ends up with the beginning of a long history and a lifetime of psychiatric intervention, most of that being involuntary. So we can look at drapetomania and say that sounds ridiculous, but the truth of the matter is that we have some modern day sort of examples of someone pathologizing people's protest action. And we saw that also come up in other places throughout the history of African-American liberation struggle, where people were pathologized when they were in fact trying to fight for their freedom. So I invite a deeper dive into, Samuel Cartwright, if you could tolerate it. But so there's a brief, and I stopped really early on, but it's still unfolding. I want to be clear about that. And so when we look at the timeline, is the arrival of first enslaved Africans in Jamestown, Virginia in 1619. And we see in 1745 in South Carolina, the first sort of legal, it actually is one of the early legal cases around mental health. and in some ways forced incarceration when you think about it, where the state of South Carolina had to outline the responsibilities for each parish to cover the costs for the care of lunatic slaves when their masters couldn't afford their upkeep. Now, let's understand that people were not in any kind of healing spaces. They were probably pretty much locked in poorhouses and other kind of places where there was no treatment of any kind, even comparable to what white patients might be getting. But that the law pretty early on decided that there need to be some effort made to provide for the care of folks. Mostly it was to cover the costs for the enslavers. And none of it was healing. So in 1773, we get the first public hospital for white patients, basically, which is now Eastern State Hospital in Virginia. We have in 1774, the first free Black woman charity is admitted to the public hospital. But again, admitted is a misnomer because she basically, I believe, was put in the basement. And so it wasn't like she was being sort of treated comparable to the white patients. In 1829, Jefferson, a 14-year-old enslaved African American, is admitted to South Carolina's lunatic asylum as a favor to his master. He was housed, pegged in the yard. In South Carolina, this has a lot of history, and I think in some ways they've tried to document it and also tried to hide it. But what I also noticed when I was digging through their records is the process by which they, by policy, people of African American people ended up in the 60s not getting out as often because what they needed was a requirement was a home visit to get for someone to be discharged. And if they didn't have social workers that would go to Black homes, people didn't get the requisite home visit to get out. So people got stuck oftentimes as well. I mentioned the 1840 census. James McClune, I believe is his name, was an African American doctor. Him and a group of other folks, abolitionists, challenged 1840 census because, and this is why the census matters when we're fighting so hard for the 2020 census, is because census matters, aside from like basically districts and all the kind of things and funding, is that it's a document that tells the story of who we are in so many ways. And so the 1840 census, because of the shenanigans that were going on, was that it reveals that there was almost no insane slaves in the South, but the rate of insanity, increased dramatically among free Blacks because this was the policy and the white supremacist ideology of freedom makes people, quite frankly, nuts, and that people who are fighting for their liberations and people who are also trying to help them must be insane. And so there was, again, challenges of that, but that was, again, policy that had an impact on us. In 1846, Virginia legislature approves the admission of slave patients to the public hospital. 1851 is Samuel Cartwright's, and he also had another one, Drapetomania Dysesthesia Ethiopica, which was also basically called rapscallions. So it's people that were resistant, dropping, wouldn't work, and other forms that we might see today as acts of resistance, which could be deadly if you were an enslaved person. To refuse to work could get you killed. And yet, again, he pathologizes those acts of resistance as mental illness. 1863, again, Emancipation Proclamation, freed some people, not all. Civil War, Reconstruction. And again, you see in that place, that's when they built Petersburg Hospital in Virginia. And again, devastated post-war economy. And again, the desire was to prioritize building a segregated hospital. And then in 1933 was the last freestanding public hospital, which I did not have an opportunity to visit, which is in Taft, Oklahoma. And it was the second facility that had all Black staff. The other one was Lincoln State Hospital in West Virginia, which actually has a kind of fascinating history. And I invite you to go to Separate and Equal to see a little bit more about that. Texas was going to set up a segregated hospital, but they didn't realize they needed it for white people, so they said no. And so they created a segregated psychiatric ward. But in 1955, there was a riot where basically the Black prisoners were protesting the conditions. And a 19-year-old young man led it, and they actually took control of the facility for a while, and including hooking the superintendent up to an ECT machine, but they couldn't set the dials right. And I want to say that happened in a couple of different places, and it speaks volumes about what people thought and felt about that they did not perceive that to be treatment, but felt like it was torture and punishment. And in reading the articles about Ben Riley's leading this uprising, the language was, we don't know what they want. He's just showing his body, blah, 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 blah. And he's basically trying to show where he was beaten. He's talking very clearly about the need for exercise treatment, adequate food, and those kind of things. But again, he gets pathologized as the rambling of an insane person when he's really trying to tell the story. 1962, Mildred Bateman, and I invite you again, take a deeper dive into her work. But she was appointed as the first and only West Virginia State Director of Mental Health, African-American woman. They had the best trained people. I had an opportunity to interview her as part of this project. And she and Lakin State Hospital, again, I'm not trying to glorify it because it was in fact an involuntary facility, an asylum, but they had the best trained staff in the country, all Black facility, and partly because racism and segregation, because Black social workers and psychologists and physicians that couldn't work anywhere else could come there. And such that they ended up building a separate building for white patients that wanted to come and see the Black doctor there because it was the best treatment. But there's just, again, a lot of stories about, and in that's embedded in the history, though, is the kind of innovations. And that's one thing I want to just raise your attention to when you go down the deeper dive, is not only was there a history of oppression, there also were histories of resistance, and there's a history of innovation and collaboration. And one of the things that someone talked to me about was like the Lakin Way, and part of the sense of what made Lakin unique, aside from being completely African-American, top to bottom leadership, but that people were kind of a community, as one of the social workers that I taught to had been there in the 60s said, like, you know, when you literally are living in the same place, and staff lived in the same place, like on the wards, because they were dropped in the middle of nowhere and there was no other kind of housing. And it says you just don't forget or ignore people's humanity when you're literally taking a shower next to them, and that you're dependent upon them to help keep you and other people safe. And again, in the context of incarceration, voluntary incarceration in the psych hospital, I think there was a way that people thought about each other and thought about each other's community that was important to understand. And the question is, how do we take that where we are, you know, we might be having different experiences, and certainly people have more power, remember, plus more power, but is there a way that we can sort of figure out how to co-create healing services that honor everybody, that really honor folks, and that we don't lose sight of people's humanity. Again, 1965, there's an incredible woman, Jessica Simpkins, who is was a South Carolina activist, and she did a beautiful intersection of labor, civil rights, Black workers' rights, and push for, you know, desegregation within the South Carolina psychiatric hospital system. And she just stayed all up in them and they were terrified. Like literally, I went to go do this interview in year 2000, and you could hear people's voices shaking as they even mentioned her name, because she basically really stood up and fought and tried to keep visible the conditions for African-American psychiatric patients and the substandard care they were getting in the state of South Carolina. And in the 60s, the other thing that I don't think I had in here was, and the 70s was basically, again, a revisiting of Great Pennsylvania in some ways, where basically a lot of the civil rights activists, Black liberation activists, were basically being framed as being mentally ill for their resistance. And so what we saw were suggestions of psychosurgery, unethical experiments on young children, and people being locked up for doing hunger strikes in jail, because civil rights workers in Maryland were arrested They were put to jail. They went on a hunger strike. What they realized is that if you think jail is terrifying, let me show you how you can get lost in the psych hospital. What they didn't understand is they sent them to a psych hospital that was run by someone who had basically escaped, Nazi Germany. And basically, this doc who understood oppression as a Jewish man said, he evaluated them personally and said, no, they are not mentally ill. They are simply trying to push for their freedom. And so in some ways, it's like when you don't know all these stories, it's saying like he was the right person at the right time with his own history of oppression that recognized and was willing to stake his professional reputation on saying this is not what's going on, and we will not be complicit with you disappearing people into psych hospitals. That was the thing. 1990s, the violence initiatives, really were again going back and saying there's something wrong with these kids. There's something wrong with these kids. We need to treat them. They all have, schizophrenia or whatever. And we're going to basically like have these conferences to talk about, not talking about the conditions, poverty, inadequate education, poor housing, but again, going back to talking about there's something inherently wrong with these people. And there were people like African-American groups and activist groups, Black associations of psychologists and social workers, and Peter Braken was a very outspoken person about that as well, of saying, and shut that down. That was being funded by our tax dollars. And so we go back and forth. And so while I'm going to stop there, understand there's ongoing iterations of this. The one thing that I should have added to this is that for those that are familiar with the Olmstead ruling for people's rights to live in community, that was a case that came out of Georgia, and I had the privilege of working with Susan Jamison. I was a lawyer on that case at Atlanta Legal Aid, and that person that was the named plaintiff in that was Lois Curtis, who's an African-American woman, who then actually told her friend Elaine Wilson about it. So it's Elsie and EW, but Lois was an African-American woman who had just been repeatedly put in places that were not safe for her, and so really gave us this opportunity to think about people's right to live in community. And that is still a fully unfulfilled promise. But I think it really was people like Lois and Sue and Elaine working together to put that out for people. So this is a little bit about the history. And the reason why I want to talk about the history of, and just like taking a moment to just reflect, like just take a moment to reflect. Why is it important for mental health advocates and activists to know about this history? Why is it important? How does this knowledge impact how you think about our profession? And what are some present day values and practices and policies that may have their roots in these historical inequities? And I think for myself is that I went to a very nice graduate program in St. Louis, and I was taught nothing. I had a sister that was incarcerated in the hospital. I didn't know to ask, to notice some of these things, because I didn't have a framework for thinking that a hospital could be so oppressive, and good people in those places being asked to carry out oppressive activities. And so when we don't know this history, we just it's very easy to assume that it's always been this way, and there's a perfectly good reason for why it's the way it is. And if this is a mental condition, and we don't realize, like, even the DSM is a relatively new document when you think about it. It's not even 100 years old, and it's a lot that's made up too. But but to think that if we don't understand the history and we don't challenge why we're saying this, why we're naming something, and is there another explanation for why this is happening for people, and also through the lens of how does racism affect how we name this, how we treat this, how we respond, and how we might be in fact complicit. And I was sharing earlier that I had a crisis. Like, I sort of stumbled into this history, and when I started to sort of notice how toxic it was and how abusive it was, I mean, I'd always had a lot of pride in being a social worker, and suddenly I had a lot of shame about it. And so being able to then come back and say, was there a way that I can I transform this? How do I make this better? How do I challenge this? How do I tell these stories? So other people will know, because if I didn't know, I suspect other people don't know as well. And so it's really being able to go back and find our place to repair. It really is about reparations, repairing, and then looking at some of the present day values and practices and policies that have roots in these historical inequities. I'm just going to sort of name this, and I really invite you to go do a deeper dive into. David Anderson Hooker is a colleague of mine, and we did a training film together and worked together with a group called Coming to the Table that brought together linked descendants, so people who were the descendants of enslaved African Americans and people who were descendants of the enslavers. And in part of that, David did a lot of conversation about like legacy and aftermath, which are like the stories, the values, the myths that we tell, and then the structures that we put in place to support those. And so when we talk about white supremacy, that's what we're talking about, not just people running around in hoods, although that is in fact white supremacy as well, but that the things that are almost feel like normal as things should be, because there are stories about this is how it is. And oftentimes those stories are very wonderful and happy people. Dorothea Dix is generally probably seen as a very positive person within the mental health field. I don't particularly find her that, because she said things like basically Black people really did not have sufficient humanity to experience melancholy. So we couldn't be depressed by our conditions. We were in fact almost subhuman, and that she could go and see through the South and go to St. Croix and see enslaved people being brutalized, but not fight for their liberation in the way that she was fighting for the liberation of predominantly white people in psychiatric facilities. And so we have to watch how that the lens through which we look at this stuff, and especially when there's this mythology about it and meaning that we assign to our practices without understanding the historical roots of them, and then that we prop those up and perpetuate them through other kind of practices and policies and systems, which is why people are so furious about talking about actual history in schools, because then we'd have to really look at how do we manage to resegregate the schools within 50 years, and what pressures are brought to bear to, and who benefits from having such inequity in our educational system. So it's really important that we look at history. It's not that history is wounded, that we are in fact wounded, and that we, in our wounding and in our desire to obscure facts, continue to perpetuate violence against people in multiple forms. So the 7 healing questions, in some ways, looking at historical harms that have occurred in all these ways. And I wanted to really acknowledge my colleague, Pamina Yellowbird. She did a beautiful monograph in the same project that I was working on, African American, about Native American history. And we spent a lot of time together talking about our project and the pain of carrying all this stuff. And so one day we were having a conversation about like, how do we bear, like when you have to confront this stuff, it's very painful. Like really confronting racism and white supremacy is painful personally, culturally, community. It makes for painful conversations around holiday tables. And so she told me about some questions that are offered. She's with 3 affiliated tribes in North Dakota, along the Missouri River. And so so we talked about sort of what some questions that she had that were really important. And her initial questions are, when someone was in distress and went to a healer in her community, they were asked what they call the magic questions. What happened to you? How does what happened to you affect you now? And what do you need to heal? And we sat with those questions as we were doing this work, about like how we were being affected, even by things I didn't even know. But the absence of certain information was harmful. And so I just remember thinking those 3 questions were powerful. Like that would be a great intake. And so what happened over the last 20-some years is I have built on those, always going back to acknowledging that those questions came out of another community. They were offered to me in the spirit of healing. And so every time I've added to them, I've gone back to Pamina and said, look, These came out of your community. I'm thinking about adding this part. Does it fit? Does it honor the story of your people? Does it honor the way that you offer me these questions? And so this is a way that, I know, like really cultural appropriation is real, but that I think there's ways that we want to find sort of cross-cultural collaboration in ways that are really honorable, that empower folks and are not just extractive, but saying, how do we make this something that heals all of our community, but also always going back and thanking her for the gift of sharing something that she didn't have to share out of her community, from a community from which so much has been taken anyway. So, one of the things that we do is we begin with our individual stories and explore how we are personally affected by historical events, but how we must expand our inquiry to understand the larger social, political, economic, and spiritual aspect of historical trauma. Healing historical trauma requires a social justice perspective, focus on addressing and eliminating the aftermath and the legacies of historical trauma. And it requires an understanding of multi-generational transmission of trauma and acknowledgement of the ongoing impact of harm to descendants. Healing historical trauma requires the creation of spaces and processes for grief and disappointment and helplessness and anger. And, people have different times and different ways of moving through that. So we have to always create lots of new spaces for it. It's like a one and done situation, because so many of us have carrying the pain literally of our ancestors, things that can never be voiced. And oftentimes that will also raise up into what looks like psychiatric disorders and expressions and symptoms, when in fact, we're trying to express the depth of their pain. Healing historical trauma requires the creation of spaces for recovery and celebration of resilience and creativity stories. Like people always, the vast majority of people who are in traumatic reactions, having mental health crises, don't show up at our doors. And so we also need to go look at, like, how did people make it through? And that's something I refer to later on when we look at the questions. And it requires acknowledgement of harm done, like, and meaningful apologies and reparations. It's not sufficient to say, okay, yeah, that was in the past, and we're getting a lot of that right now. Is that we got to talk about, this is what happened. I hear the impact, and this is how I can ensure that it will not happen again on my watch. So the 7 healing questions, and as I said, the 3 original ones that Hermione shared with me is, what happened to you? How's what happened to you affect you now? And what do you need to heal? And I have since added 4 other questions that have come through a lot of conversations with other people. But what happened to you is, like, it kind of presumes it's something outside the person, that there was an event, that is this not just bad biology. Something happened. And so inviting people to look, that something happened, and inviting them to think about, one is also make sure that the thing that happened has stopped. One of the things that we talk about, and I first learned about this through working with and reading the works of South African and Palestinian therapists, that it's like they're talking about continuous traumatic stress disorder. There's no post. We would love to have a post in our community as African American people, but there's no post. Like, about the time you process one police murder, then there's like 3 more. And so people never have a chance to recover and go through any kind of traumatic healing response, because there's always something dropping. So asking people what happened, asking communities what happened to your people, and then asking, how does what happened affect you now, which presumes that there's an ongoing impact, and invites that person and that community to say, like, oh, that just didn't happen back then. It's having an ongoing impact for a lot of different reasons. If you were a Black resident of Tulsa that had been a processed community, it gets burned to the ground. It gets forgotten by history for the most part. And then probably a cascading of people that could never recover their wealth, resources, and sense of safety that was lost in that time. And again, I would also invite people, if they have not gone, to visit the Equal Justice Initiative Museum in Montgomery, Alabama, which I think does a brilliant job of really making us confront the history and its ongoing impact on people. This is a question that I added, and again, as I said, I checked back with my mind and was in constant conversation with her about any additions, was how, in spite of what happened, have you been able to triumph? And this one was offered to me through a colleague, Mukunga Kenyela, who's also a minister, and he was talking to me about, like, what we call narrative therapy, and in our community it's like testimony therapy, because he says, and you go to Black churches, people are telling testimony, how I made it through. and that had been healing space that was happening all the time, when people were trying to tell their stories in these, what was at that point for them, safe spaces of their spiritual communities, and being able to say, this is how I've been able to triumph, and I always, when I'm talking to people, I have them think about, our communities may be very under assault, under resourced, all kind of things, but always going to look for those, what I call power sparks. What is it about us? What have we been able to draw on that's intrinsic to us that gives me hope, that allows me to get up another day and fight? And I think that inviting people to find that, inviting communities to find that, inviting affinity groups to find that for ourselves is really crucial. The good social worker in me came up, thought that the external factors, person and their environment, right? So what external factors that create and maintain what I call power wound, that traumatic wound, or the personal and or community sense of injury. Like, we got to look around us. It's not just coming out of nowhere. It doesn't seep into the vents. Things happen. Someone did something. What were the hands? Who were the hands? They got names and addresses that created this wound and that maintained this wound. And there's all kind of ways that we do that, including by keeping people impoverished, and not giving them about choice of care. And what do you need to heal? You or your people need to heal. And that is both one, what is still wounded, as well as what needs to be brought to bear to support that healing. What I realized through my own experience with clinical depression, which actually was a springboard for me doing this history, was that I did a group presentation with two other friends, and we were looking at depression, clinical depression. It was called Black Women Raging, Healing, and Reclaiming Power. Is that we're looking at it from a teenager, someone in their 20s or 30s, and someone in their 40s, and from a role of a parent. So we're looking across ages, but also in terms of our social positioning as daughter, therapist, and mother. And having those conversations to prepare for the workshop, one of the things I realized that there was something fundamentally healing in that, which is that I was able to create meaning from something that had previously left me just feeling broken. So helpless in the depression. And so it made me think about, what's a gift that I've been able to bring forth from this experience? What did I learn about myself? What meaning did it give me? And I realized that for me in my work, folks, that's a really significant piece. People have to make meaning. We will make meaning, and it's going to be either meaning that's useful or meaning that is detrimental to us and to our people. And so inviting people to think about, like, yeah, you didn't want this to happen. You wouldn't wish on your worst enemy. But what do you know now? And I talk about cracking open and finding my gifts. Like, there was things that I had to do and that I learned about myself that I wouldn't have learned, I don't know, in other ways. Hopefully there's other ways to learn it, but that what I was able to do is realize that I had strength that I didn't realize, that I could lean on people that I might not have leaned on before. And so I found that my community could hold me. And then the last kind of thing for me, and it's also in a process of healing, is that what lessons, wisdom can you share with others? So it's not sufficient that I have something in myself. It's really important that I take that out there and share that with other people. So what can I teach and share and exchange and expand with other people that, again, makes community meeting and offers hopefully healing and resistance, and using these questions in the way that, again, I think they can be used. I use them in my clinical work. I use them in my coaching work. I use them in my community activism. Is just inviting us to look. It's a lens through which we can analyze something, because we need to name something, analyze, strategy, and act. And so that's the way I kind of think about the healing process. And I think that's also how we transform our organizations, is that we need to name where we really are, what we've really done, what's working, what's not. We need to, name it. You need to, sort of analyze what meaning, how did that come to be? What are the roots of that? And then think about strategy. Now, what would be really more helpful? And making sure all the people that are affected are at the table, and lifting up voices that have been out there doing the work in community, outside off our radar, whether those are traditional healers, activists, whoever, is making sure all the people are at the table who bring the wisdom. And I think this is a really important time especially in African-American communities, where some of the best innovations and best thinking in my mind around like healing trauma and shame and other things are coming out. Activist communities are coming out of our activist scholars. It's coming out of folks in the street, barbershop, I mean, everywhere we show up, and that we want to make sure that we have the wisdom and humility as mental health professionals to go to those places and listen and ask and say, tell me more, and then not steal their work and label it as your own. So guiding principles for the key questions, for me, and these are just my values. Let me just be real. These are my principles that, because they make sense to me, is clinical and organized belief that all wounds can be healed. I believe that. If I didn't believe it, I wouldn't be doing this work. I believe that all wounds can be healed. It'll take time, or the conditions that it's going to take, but I believe that. The clinician, community organizer, and clinician clients community must develop a vision of healing. I think that's something that's really important. That's related to wholeness and restoration will be the goal of all discussions. Like, what are we doing there? What is it? Who's still out there? Who's the outlier that is not getting touched by what we're doing? How often do we go back in our work as clinicians and ask that question? Okay, this is working. And I could go on a full-on rant about evidence-based practice, but oftentimes we don't look at who's not being helped by this. Like, this is it's beautifully packaged. It came in a great binder, went to training, we got certified, but who's not getting affected by this? And there's a really beautiful thing that happened with Brene Brown, that some folks that she is in connection with, African-American writers, scholars, activists, sort of lovely rolled up her and said, like, we love your shame work, but we're not seeing ourselves in it. And if you have not seen We Are Our Best Thing, which is a collection of articles. Again, it's one of the best things I've seen around African-American mental health in a very long time. And it did not come out of a clinical sphere. But what she was able to do was hear what people were saying, critiquing her, and not get defensive, but move out the way and let people tell their own stories. And I think that we can be reminded that over and over in our work. Where are we doing that and where are we not? The process of naming and acknowledging wound is fundamental. And so it's really hard. You can't heal what you conceal. It's also hard to heal what you offer up to people and they say that's not really happening for you. So you also have to be in places and you have to be willing to hear people tell you the truth, even if it makes you uncomfortable, so that they can be healed. So it's not my job, and I don't get to define for someone in another group, marginalized group, like to say, well, that's not your experience. If they tell me it's their experience, I need to believe it's their experience. That's what I want for my community. And the creation of safe enough space. And I always talk to people when I'm doing anything, like, there's no safe space. It's wherever I am. It's safe enough space. And I can show up and I can decide if there's the support in the room for me to be vulnerable and to share, and have pushback, or places that I can go that will help me. But we need to create that safe enough space for the naming of the wound and the emotional vulnerability required to do that. And that's a risk. And I think it takes a lot of courage. And I think a lot of people show up for over and over at work. The break room conversations, maybe not break rooms, since a lot of people still aren't back at work. But I think sometimes when people are like with the new, everybody's trying to do diversity, inclusion, and equity stuff, and folks of color and other marginalized groups, you're like, we're going to talk about, transition, and you're just sliming people with your pain and your ignorance and all this kind of stuff. And we'd have to be really careful, especially when we're not members of those marginalized groups, to make sure that we are allies. And when I say allies, it's like really listening and making sure that we are shutting down stuff that is harmful to people. And it's harmful because people are oftentimes really screaming, saying, that is harmful to me. And to like really hear that, so that we can have enough connection, enough trust, and enough safety to really begin to untangle the toxic roots of our profession. And it's important to create the container. So like, we have to think, and every person and community needs a different kind of container. So sometimes you ask, like, what's the container that you need? I need a chance to pull out. I need to have affinity circles with just folks like me, so I can just sit and just say, because oftentimes there's never been a place to really fully think through what I'm feeling. And so we have to create those containers and mentally not block the creation of those containers. And identify resiliency skills. Every single community, I don't care what you think it is, any family, they have strengths in there. And if we are so used to looking for pathology that we have long since stopped looking for like the things that people are doing that are amazing, that are what I call footholds of hope, And inviting someone to look over here, like we see the pain, we see the problems, we see that, but like we want you to look over here and tell us about the things that people are missing about who you are, who your community is, that can offer a sense of power and or agency. One of the things I have a book that I co-edited with my mentor, Elaine Penderhughes, who has been working around issues of race and culture and ethnicity for since the 1940s, literally. And she still is alive and amazing and holding me accountable for things. But in that book, I wrote a piece about, I think my introduction was that in spite of all the funding thrown at empowerment programs over the past few decades, few human service workers have been trained to analyze power dynamics, and even fewer have been given the space to struggle with power, power to, power over, power within, and power with. On a personal level, as part of our professional training. This leaves us vulnerable to frustration and power abuses as we attempt to ameliorate conditions for our clients without having the full understanding of how the problems relate down, what maintains them, and what collaborative action needs to be taken to remedy these power inequities. And I'm just super grateful for Elaine, who was a visiting professor at WashU and created a safe enough, intimate space for me and other people to struggle to listen. And so in that spirit, I've always, and she asked two questions that I think are also really kind of good and mental health people should ask is, when have I felt powerful and when have I felt powerless? She had a lot of theory, but those two questions are what I remember, 40 years down the line, about helping me on a very visceral level to understand that and what it meant to me and how I showed up with my experiences of powerlessness and power in my work as a social worker. And so I just want to offer that to you and to say, if I don't know, go, and there are some good resources out there, including Understanding Power. But I just think it's always a place where we need ongoing space to struggle and to be wrong and to make mistakes and realize, oh, there's a whole area I didn't think about, and get over ourselves about wanting to look like we know it all, because we don't. I still have huge spots that I miss things and I didn't understand, and I keep hoping that I every day have the humility and openness to learn. So I want to talk about elements of emancipatory practice, and this is a sort of a blend of my thinking and Jerry too, I believe Jerry too. And if you Google him, I should have that somewhere, but he has a whole downloadable book about power, and so the things that help me think about and guide my work around it is that one is emancipatory practice, something that is really focused on liberation and emancipating people from all kinds of constrictions. And we are surrounded in mental health, we are working in the language of all kinds of constrictions. And so it requires a basic understanding of power and its multi-level operations. And I think sometimes we can look at people and say, well, they've got power here, but that person may not have power in other ways. And that power is happening in so many different ways. I can literally be in one room and be a person of power in that, and literally walk across the hall, or even someone in that room say something, and suddenly there's a different level of power operating. So we want to just understand it. And one of the things that, and it's grounded in power as a relational experience and not a thing or a static state of being. One of the things early on in my conversations with Elaine Penderhughes, as co-editor, along with Pat Romney, is I said, power is almost like a rapidly mutating virus. Just when you think you understand it, it sort of changes its nature. And so we're always having to think about, what is that? What's the power in it? Who has the power? Who benefits from whatever decisions are being made? And if we're not constantly interrogating that, we are not helpful, and we're going to do harm to people, especially folks who are in groups that have been historically marginalized. So to always ask, who's got the power and what's my real power? And because I feel helpless about something does not mean I'm acting without power, and especially dangerous when people are in roles of providers and gatekeepers of resources, that we really don't have the luxury of doing that nonsense anymore. To say, I have this kind of power, this is where I don't feel like I have power, or I don't have enough power relative to somebody else. But to be understanding, like it's a relational thing about, based on who I am and who I'm dealing with, I have more or less of what I call power. It operates on a foundation of power together and with, that I am in co-creation with somebody, that this person with the lived experience of their unique life and their unique experiencing of whatever's going on for them is the expert. And that I come also with resources and understanding and connection with how maybe other people did it, but that we are together in a co-creative process. And I have to say, there's nothing that gets you clear about that than being in your own therapy or having to go and have involuntary or semi-involuntary treatment of your own to get real clear about, like, oh yeah, I need to really stay firm on that one, because it's so easy to lose your power, especially when you're at a time of incredible distress. And you have to count on people to do right by you. And so when we are holding that space for people, we need to make sure we're doing right by them. And you do that best by asking what would be helpful. What do you need? What's been helpful in the past? And so emancipatory practice is creative, ever-changing, results in growth and authentic healing, which sometimes makes it very different to get kind of evidence-based, because it's always changing to meet the needs and adapting. And we've got to be able to adapt and not get into rigid kind of programming, because that's how the model's supposed to go. When again, we are watching people get crushed by that model. It's an ongoing process of analysis and dialogue, making sure, like, sometimes we get so busy in our work that we don't have time to talk. And that's where, and think about, is this working? This is a new thing I'm doing. I always ask people when I'm doing trainings, it's like, what's this cool stuff that you're doing that's really helpful to your clients that you don't tell your supervisor about, and like, we need to raise those up. That's how we get new theory. That's how we get new interventions, is by having the courage. I'm not saying play with people's lives, but it's saying, minimally, if it's working in your life, you might want to ask and have a group of other people, including folks who are receiving your services, to say, is this helpful? Why is it helpful? What would be even more helpful? And so emancipatory practice involves that kind of ongoing dialogue. It requires honesty and personal inquiry into one's own use of power, is compromised by denial of power or surplus powerlessness. And surplus powerlessness is really about, people who act with power, but then act like they don't have the power, which happens over and over. And so we just need to sort of be thinking about, like, if we're committed to liberatory, emancipatory practices in our work as mental professionals, what does that look like? Where do we get caught up? Where are the possibilities? Where are the openings that we're not fully utilizing? So connection, trust, compassionate witnessing, and creative visioning are not yet evidence-based practices that the government will fund. Maybe they're getting there. We have to reclaim a willingness to make mistakes, wander from the path, and just looking foolish if we're going to bring about the needed changes. And I go back to looking at why this history is important, because with embedded in all of that, where I saw incredible creative, making a way out of no way kind of practices that rose out of some of these segregated hospitals. Some of the first family therapy programs came out of Crownsville Hospital. That was basically volunteer-led family therapy sessions. And this was done because Black members of the community of Baltimore and surrounding areas were concerned about what's happened to Black folks that were being disappeared into Crownsville. And people stay connected not only to their own family members, but to other members of their beloved community, and created a process of family therapy, basically, but family conversations that were led by volunteers. They were not trained mental health professionals. And so we don't want to miss those opportunities with our rigidity and our fear, quite frankly, of not making mistakes and getting fired. At the same time, we need to hold and check in with the people most affected about, is this helpful? Is this working? What's making it work? And that's how we create new practices. So final reflection is, really, and I love that, this conference is really about not only what you get here, but also what you build out, and that people will be checking back with y'all around, like, what did you do? How did you take something in this and turn it into something that can change how you practice, change how you really understand and challenge the, quite frankly, racist roots of the mental health system here. And how do you plan to contribute to broader systems of change to ensure services grounded in anti-racist values, practices, and policies? Like, take a moment to just think about, what could that be like? What do I need to do? Who can I do it with? what are resources outside of the mental health field, because let me tell you, that's where all the good stuff is anyway. And be able to co-create genuine liberatory anti-racist values. But we know it's that because we really have gone in and looked at the root. How, we assume that things have always been this way. Even who gets to write in DSM is like, who controls that? Who's in there? A bunch of white dudes. Why is that? Well, and all the kind of pieces. And so we got to look at that pipeline of control that we could say, well, that's just who's there, but to say it didn't get that way. It's saying that, when I was going to graduate school, there were no African-American women professors. And I went and talked to the dean, and he told me, he said, well, I can't, we can't find qualified people. And say, I'm not having that. Like, you basically, I looked at, like 4 of your staff here graduated from, did their doctoral work in this program. Grow your own Black people if you really want to have folks. If you're saying it requires a PhD, and there are all these people I'm sitting next in class who I know to be brilliant people, then why are we not investing in people to do that? And to sort of stop at, we can't find anybody, is actually a reflection of some serious racist attitudes. And so we need to be able to say, wait a second, I don't think that. And so it does require that you have spaces and people with whom you can, interrogate this, struggle with it, and to be creative with, and to, quite frankly, face the pain of it. And for folks who are not, people of color, specifically African-American people, is that don't have that be on the backs of the people who are daily experiencing oppression. Struggle with it on your own, read, ask permission before you dump on people about your confusion or even your newfound awareness. So I just think this is an opportunity to build new connections, and for all the state responsibilities to transform the system to something that might be someday authentically healing. So I thank you for your time.
Oh my goodness, Vanessa. You are a giant. You're a giant in the social work profession. You are a giant in this world of thinking from an anti-racist lens about the history of psychiatric movement, of the professions beyond social work that are part of psychiatry and psychology. You are a giant in thinking about healing. I started off saying I wanted to give thanks to your ancestors and my ancestors for bringing us together. And I really just can't say thank you enough for all of the people who came before you in your life, the people that you mentioned that you built ideas with in this presentation. I feel like so much of what you did was a really beautiful, powerful example of what you're suggesting that we do. Yeah. I took so many notes. I guess one of the first things that I wonder if you would talk a little bit about was this idea of, instead of cultural appropriation, how it is that, and I took a note on it, you said this idea of how do we create meaning from something that caused injury, cracking open and finding one's gift, but also to build out ideas with other people and acknowledge their contributions. And I feel like that's what we're trying to do with this work, anti-racism approach to crisis continuum of care. Can you expand on that a bit, please?
I think in some ways it's about really, like, one is inviting people into the room and acknowledging their expertise and honoring it as such, so that the only person, like where we still are very much stuck, if you don't have the right credentials, you haven't gone to the right places, if you didn't rise up, whatever. And so we don't acknowledge. So there are oftentimes people in these rooms who know things that could be transformative. There's always people in the room. Let me just say that. There are always people. We never ask. We never ask. We, in fact, shout them down by basically throwing letters and degrees at them and then wonder why, you don't get this wisdom. And so I think that's really important. And when I talk about the healing questions, I can't imagine doing anything other than going back to Panina, because I just remember the moment of just generosity. I mean, we were struggling. I did not realize how toxic doing this history was. And it's traumatic material. And so I basically was vicarious trauma in reading all this stuff. Like I am down deep in the bowels. I'm sitting there thinking, oh my God, I owe these people money still, and my profession sucks. and and I'm mad because they never told me. So there's all this thing going on, and I just was like burdened. And Pomina and I have a conversation. Like I said, I don't know if I could do it. And she actually at that point said, look, I can offer you some ceremony, which she didn't have to do. She invites me into some ceremony, but part of what also happens with that is that she talks about these questions. And I said, Pomina, this is groundbreaking for me. When I was so suicidally depressed, if someone had asked me those three questions, I'd have gotten through it sooner, because it presumed that I was okay, and then something blew through my life that maybe not okay. And that it had an impact, but then that begins to make me think that there's another side of it. So to me, the power of those questions was like, yeah, but it also never occurred to me. And we were using these questions, the 7 healing questions, in a recent publication, and somebody, because this is how it also happens. So someone was doing that, and they gave me credit, but I know it only takes like 2 iterations for my name to drop off of there too. Because I've seen that out there in the streets too. But I said, you can't say this without saying Pomina and David and Vanessa. Like, you can't say that, because there was a team of people. But most importantly, even if my name drops off, Pomina Yellowbird's name should never drop off of these questions. And so it's also being, just saying, like, being solidarity, but respect and appreciation. So it's just not like being politically correct. It's like just being a damn decent human being and not stealing people's ideas. Like, it's just, you just don't steal people's ideas. Like, it's basic kindergarten stuff. And so for me, and that opens up when there's that kind of respect, there's that cross-pollination, there's that super commitment to never ever forgetting where you got that information. Then, and it's not extractive. Then, cross-cultural collaboration becomes possible. And in the absence of that, you always have to be questioning the exploitative aspects of it. Because if I'm not respecting who you are, I'm not respecting that wisdom came from you. And I'm not sort of requiring that I can't listen to you unless you've got all this stuff going on for you that I've decided is the important stuff. And, as folks of color, you can be in so many meetings when someone's just rattling, you're like, oh my God, I know they wrote 4 books about that, but that is just like ridiculous and not helpful and harmful. And then there's somebody over there, like sitting in the court, like my mom. I tell people, I was doing an interview once with Michael White, the narrative therapist, Michael White thing. And I was telling him about, like, I'm because he just listened. He just listened. He's not saying much at all. And I remember somehow saying in that conversation is, I want my work to reflect the face of my mother, because she was a person that listened in her community. She was one of those people that they came to. You would thought she was a physician, because if there was something that was happening, like, this, take her to this room, see if she knows what this is. And if you need to go to the hospital, like, she was triage. And it became really important to me that my mother's wisdom and the wisdom of all those other folks that are just in the community doing good stuff all day long. I remember being in a training once, and someone was saying, and there was a lot of violence in the neighborhood, and there were some shootings going on, and somebody in the group that I was training on the healing questions, and so what happened? They said, oh, that whole thing that's going on where there's all this shooting back and forth. The core of that is the young man that started off the shooting. His grandma died, and this boy is just in grief. He's in grief, and no one's seeing his grief. They're seeing his violence, and they can't interrupt that until they see his humanity and see his grief and feel how lost he is. Now, we do need to take the gun from him. I ain't mad at that. But it's like this whole other piece. But if you don't have people in the community, people who are there, who sort of know, like, oh, you think that's what that looks like? This might be something else. And a lot of times I'll tell people, if you sort of did your own kind of assessment, like you did an in-home assessment of your own family, what would people see? What would they write up about you and your family? And what would they miss that is amazing, that's life affirming about your family. And so, all of that, it really comes down to the thing is if I respect people and I respect their wisdom and I assume I'm not the only smart person in the room and that I understand that people have a history and I probably don't understand their history and I can ask them, but they get to tell them the way they want to. And they can also choose in that moment not to share that with me. And that's got to be okay too. And they might refer me to books because they've given that spiel, they ripped out their heart to all kind of people who walk right over it. Don't be that kind of person. That answer the question, all.
Oh my gosh, and more. Are you kidding? This is why it's such a gift to sit with you. And this idea of the honorable cross-cultural collaboration. I just want to hold that because what we are asking is for people to take your presentation, look at their work site, and say, what is at least one thing they can do to achieve some anti-racist outcome in the crisis continuum of care and or justice diversion work in their community.
Okay.
And that cross-cultural, that honorable cross-cultural collaboration, I think is something that we don't get to learn oftentimes if it's in our MSW program, or if we're psychologists or psychiatrists or whomever. We are taught of a power differential that you also spoke to in your presentation. I appreciate that you go back to this idea of power and emancipatory practice and healing. I think about what it takes to be that change agent at work. If you're working in a community-based organization or a county behavioral health department, it's scary. It is scary to be the person who stands up and says, you know what, we are over-diagnosing conduct disorder right now with our young men of color, our young trans people of color.
Yeah.
That is a scary thing to do because throughout history and even contemporarily, when people speak from a place of hungering for freedom, they are called crazy. They are called stigmatized. Absolutely. And we see that during the Black Lives Matter movement right now. We have seen it across all of our movements and over history. I wonder if you could speak a little bit, Vanessa, about how to be that person who still speaks up. And I know in some of our communities, it's not a choice. It is a matter of survival. Thank you very much. Mm-hmm. But it also can feel a little bit to people like, oh, I'm not going to speak up right now. Can you talk a little bit about that dynamic?
I think that is so good question. But I think it's really hard. And I was, when we were talking earlier, I was talking about my professor when I went to go work at the university where I would graduate Washington Unite. And my very first day of work, I stopped before I went into my job. I stopped with one of my professors and mentor, a guy by the name of Jack Kirkland, who also has written about race for his entire 80+ year life. And I just said, I need some guidance here. Like help me figure out like how I'm going to survive this place. I went to school here. I know how racist and toxic it is. And now I'm going to go make my money here. And I need to make money because I need to pay these people back. Right. And so it wasn't like, and he just said, bring your own oxygen tank. Like this place doesn't value you as a Black woman. Like, and he wasn't trying to hurt my feelings. He just was trying to break it down to me. Like, this ain't home. It's kind of like, this ain't home, baby girl. And so the bring your own oxygen tank was like making sure that I had him, and he made sure that I knew that he was part of that. But people around me who would care for me, support me, strategize with me, decompress with me, let me scream. And so one is I'd say make sure that you have a group of folks who can hold you and who can help you figure out where to push. And also, I think the other part of it, and I've said this, and I go and talk to social workers, is that, the world doesn't need more scared social workers. If you're not going to walk away from a job, you are a problem. You are a problem. If you are so attached, and again, I tell people I have an unnatural affection for my house. And I know if I do not give that mortgage company their money, they will come eventually and take my house, and probably really fast now because people are trying to steal houses left and right over here. But the thing of it is that, but my integrity ought to count for something. Like either I believe something or not, and I can think about, like, for instance, when I used to run, and this is when I moved out of community mental health, and is that I ran a child and adolescent program at a community mental health center. And about this time, which must have been 95, or no, let's see, like 98 or something, there must have been some changes in like regulations. So basically we're getting this sort of Medicaid pressure and to do faster, like do 30-minute evaluations and do all this stuff. And I was like, I'm up. And again, now I might have stayed and fought, and I'm really proud of people who stay and fight in those situations. But my point is like, let me be real clear. I just went and got labeled with a psychiatric diagnosis that I cared for life, and that I will always, well, now with Affordable Care, while we still have it, I was paying higher premiums because I had a clinical depression diagnosis. And you're going to basically label someone for life in 30 minutes. I think I'm a good therapist. I don't believe I'm that good. And that is a process that captures people who are poor, disproportionately folks of color, folks who are marginalized in all kinds of ways. And you're going to look at a complex life in 30 minutes, like, oh no, I can't be part of it. And so those are some of the policies that on the face don't look racist or sexist or homophobic or transphobic, but in practice, really, because who walks in the door and who gets the 30-minute evaluation versus a person who might not get anything, or adjustment disorder, because we're all here and we just want insurance to pay and we're good and I'm good, all that kind of stuff. And so we got to look at those kind of things. And when you have to say no, or when you see like this superintendent in the 60s that evaluated these civil rights protesters, he could have lost his job. His family had survived, genocide. And yet there's something about this man's values that just said, oh no, like I ain't going out that way. And there's more and more people, and you find, and here's the thing, everybody has the rabble rousing core. You find your people, you find your people and you strategize. So you're not just sort of complaining, but you're saying this has got to change. And I think that in this moment with work too, it's a scary time because people are so vulnerable. But I think there's also, like, in some ways, this worker uprising that we're not quite calling it that nobody wants to work. It's like nobody wants to work for oppressive, no wage stuff. No, we want to work. We're just not willing to be exploited anymore. We're not willing to die, literally die, for you to get rich. And so so all of that to say is that we have to have, in this mental health professions and so we have so much power to label people for lives in ways that are completely toxic, and specifically as social workers, and that we have a ethical obligation not to co-sign on that and to resist that. And but I think on a very practical level, you got to find your people. You got to find your people. You got to stay awake. You got to stay awake to what's happening. And I know when I'm talking to people in these classes that they owe like just frightening amounts of money that they will never be able to pay. And they are feeling like helpless and powerless and maybe as impoverished as they, like really on one hand, I could literally, as one for instance, literally run into folks at the breadline myself because I'm paying off this debt and something like, but we can't let that keep us engaging in bad oppressive practices and still call ourselves helpers. And so the one way you do that is you organize with other people, and you look for, because there's always other people. You always look for the other people. You see the other people rolling their eyes in the meeting on Zoom. Now you can see everybody. So the person who, if the screen goes dark, you might want to say, I think I need to be your friend. Because it's like this person just said, like, oh yeah, I got to turn the screen off right now because they talking so much mess that I'm about to get fired up in this joint. And you got to be willing to do that. And again, I am not, being naive about people's financial obligations and stress and that kind of stuff and meaning. But if you build a career on the misery of other people's bones, literally, you need to really check yourself.
So much of what you say repeatedly takes my breath away. It stops my heart for a moment. It is, it's deep, it's painful, and it is being shaken at the deepest level with truth. And so that last point, how many of us, if we're social workers, psychologists, psychiatrists, psychiatric nurses, how many of us think about we are making a living off of other people's suffering.
Yeah.
Most of us don't see ourselves that way. Most of us see ourselves as people who are helpers, who are trying to help out. And I think that it becomes especially stark to me when I look at the crisis continuum of care. And if I might, I'd like to ask you one last question that's related to this. 2021, we know that when people have behavioral health crises, whether they're suicidal crises, overdose, intimate partner violence, when we can help people recover in the community, outside of emergency rooms, outside of locked psychiatric facilities, certainly outside of jails, juvenile hall, and other incarcerated facilities, border patrol facilities, what have you, people recover faster. It is a more humane way to recover. Most of the time, we don't need medical clearance by an emergency room, right? Most of the time, if you end up in an emergency room, you're going to sit there for several hours. Frankly, with COVID-19, everything else that's been going on, we're seeing this left and right now. People with suicidal crisis, they end up in an emergency room and they sit there for hours, if not days, waiting for a bed to go to. In incarcerated facilities, emergency rooms, locked psychiatric facilities, that's not a place where people calm down, self-regulate, slow down the central nervous system, right? You're in the middle of crises all around. Those are also not places where people have access oftentimes to the cultural strengths and resiliencies that you were talking about. So there was several points where you've mentioned this idea of healing in community. And I think that's what we really are starting to get to from the SAMHSA National Behavioral Health Guidelines on crisis care, which were just recently published. We're seeing it in number, but frankly, the MAD movement and psychiatric survivors and peers have been telling us this for decades, right? So, okay, so there's my question for you. As we think about trying to divert people away from criminal justice systems, divert people away from emergency rooms, psych hospitals and such, and healing in community, can you talk a little bit about that anti-racism lens to help to make sure that the systems that we create in community are not building up again or reifying, or I don't know the word, but you know what I'm saying, like reinforcing that racism, the sexism, the homophobia, transphobia that are in those systems?
It's very still fresh for me, but I had a friend that ended up in crisis and was very much in crisis and very, it started out, they were needing help about something with police, but it ended up escalating for any number of reasons. And that involved them having a weapon. Now, this person ended up getting tackled, getting put in thing, but then later walking home. Can you tell me what their racial background was?
Yeah, they were white.
Yeah, mighty white, right?
Mm-hmm.
And again, but no one should have ended up dead from that thing. But what we know is that when certain kind of reactions happen, if they show up in communities of color, if it's a trans person, if it's somebody that we have decided doesn't value, the response to them becomes so extreme, so violent, so dehumanizing, and that it happens with such amazing consistency. It ought to tell us there's something else going on there. If we're not sitting there having that conversation about why does it happen, it's like, Sesame Street, one of these things is not like the others, and so even little kids can figure this out. And so to say, so when we have our practices, and so the more we can make sure to keep people alive, because literally here in Georgia, someone clearly in crisis, naked Black man is shot. He's naked. He doesn't have a weapon. How the hell did he end up dead? And the cop not prosecuted. And so over and over, we have to say that, and the answer to that is also not necessarily us get little social work vests and go in with the police either. It's like, one is being able to intervene before it ever gets to that point. What resources did that person have when they kept saying, help me, help me, help me, having a hard time, help me, was there for them to go first? So we have to back it up a lot further. There's the most immediate, like the crisis, how we stop people from dying. Well, one is you do that not by doing things to the people, but saying, can we take guns away from cops? Because apparently they are too scared to use them in any reasonable kind of way. But so you have to stop police from injuring people, and also make sure that the continuum of care is that people have spaces all along the way. One of the things that I love and I have referred people to as well, it are like crisis, like peer supported crisis spaces. Because when someone is saying, I'm really starting to lose it, I'm really starting to lose it, and I was thinking, like, when I was in distress, I knew I was losing it. I kept trying to, I was calling my little insurance company and smoking cigarettes excessively and all kind of stuff. And because though I had relative privilege, my blackness and my femaleness didn't protect me, but my, social work degree and the fact that my good friend was the lawyer who led the Olmsted case, I was pretty sure I wasn't going to get incarcerated. But by the same token, when I went to go see that psychiatrist, I let people know where I was. And I let Sue know to be on tap. And I also knew, because I'd done protection advocacy, what can happen. And we escalate people over and over. A 7-hour wait, a 2-hour wait, if I'm in distress, will escalate me. That person didn't get all escalated. When you ignored them, they were hungry, they were tired, they were scared, they were confused, and you left them in a place of such confusion. And so that's when we step back, when we sort of look at what happened in that whole scenario, what happened that got us there. Then we need to say, okay, so how do we intervene at this point? How do we make sure we have snacks? Like, how do you have, like, it's like something that could be solved by snacks and a water. And I remember this beautiful, it was terrifying in the moment because you didn't know where it was going to go, but an activist who happened, I believe, to be a social worker or some therapy, like helping professional, there was a woman in the street, and she was just doing a one-woman protest, and the police, you could just see them like rolling up on her. And this person put their body on the line and said, no, like, I am a mental health professional. This person is in crisis, standing in between the police and this person, and said, let me talk to her. Like, I'm not going to talk to someone that's got a gun out of me. That does not feel like safety in anybody's world. And so if we think about the ways that we as mental health professionals, especially with peers, it's like, you got to be careful about getting embedded in other people's stuff, because you're still getting embedded in their nonsense. And you're going to be the least powerful person there to change the culture in a police response to mental illness, unless you are completely running the show. So I think with the continuum, it's like we can look at all the different places, and earlier intervention, so people never get to that place, is always the best place to start. But we also have to shut down the most dangerous pieces, and we really need to have real strong, the whirling word that keeps in mind is like almost postmortems, where we're sitting there and saying, what happened here? What could have done differently? But what happens, we get so litigious that we don't want to have that conversation of what went wrong, what did the cop do? Because it's like we're trying to then go into protective mode to not get sued or not get someone criminally implicated when they need to be criminally implicated. And so we don't ever have the real conversation about what went wrong. And maybe what we should do, now that'd be kind of an interesting thing to have in a group session, is we're going to look at the facts of this. We're going to look at this case, and we've got to be careful, because I think especially around the people that are affected when it's been a member of their community injured. But to say, so be careful about that one, because it's like, it's more trauma, is what happened here and what would be our recommendations, and how do we take those recommendations collectively to the police, to the state's attorney when they're charging, to say, this is where it could have been done differently. Where are we showing up in those conversations at all as mental health professionals? Or we decide that's a silo over there. And if we're being invited to go ride alone with and do that kind of stuff, and again, that can be very helpful. I see in my own community now that people are saying, don't call the police, don't call the police, that there's a sort of a response system that is both mental health as well as economic supports and that kind of stuff that are coming out for people who are in crisis. They're either a crisis of poverty, a crisis of sort of mental health things, a crisis of just being stressed out in a world that's terrifying if you've got any awareness. And so that's good. I like that. But we have to go deeper. We got to go deeper and say, what are the things that are happening over here? While we create the safer thing, we also need to really deconstruct and look at early. And we have never, ever in this country, when we started, and thankfully getting people out of institutions, but you got out of there because you couldn't exploit their labor either. So let's be real clear about that other factor. It wasn't just like, oh, people need to be free, because we still haven't figured that part out yet. But really being able to say, what do people need? We never did community mental health at the level that we need to do. We never paid attention to the fact that if people were locked up in hospitals, there was a residential component that needed to happen for them, and that they had been separated from work for long periods of time, and that they might need help. So we never did any, like, for the little drop in the bucket where we do that, we didn't do that in any meaningful way. And then we want to talk about community mental health as a failure, and didn't ask people how they preferred to receive their care anyway, and who they want to provide it with. So maybe it's not the social worker. Maybe it's not a 30-minute session. Maybe it's 3 hours with a group of folks sitting around chatting with you. And even when I was coming into the field early in the 80s, we had drop-in centers, we had clubhouses. That stuff disappeared, and professionals just took over and crammed people through something that could be controlled by the state, quite frankly. And so there's always that piece, and there's a whole tension, like you said, the MAD movement. People have been out here. It's been a MAD movement since the first time they closed the door on somebody. That is not a new movement. Mm-hmm. And then we need to also talk about why people of color in those movements and other marginalized groups have not been, like, lifted up in the same way. You would think it was a white straight movement throughout its history. And, and so there's all these different places about how the forces of the state, show up in the lives of certain groups of people. And if we're not sort of really interrogating that and asking and saying, okay, well, have you thought about this? Then we're part of the problem.
I couldn't agree with you more. And I think that to that last point, I really look to the work of Kelechi Uboso as one of these brilliant thinkers, writers, strategists, activists, community members, who's just really moving the dialogue forward in huge ways. She recently did a presentation at a California level state conference, if I remember correctly, where she talked about, you brought it up before, that we as providers will not do certain things fearing that we're going to get sued. And she said, let's actually step back and look at the data on this. And she said, you know what? Y'all are not getting sued. You're just not getting sued at the level that you think you are. So stop using that as an excuse to not show up when people are in a suicidal crisis in a way that is humane. Stop running out and trying to protect yourself, because that's not what's happening. But what you were saying earlier also reminds me of, you were saying, maybe if we stop and ask people, well, what do you need right now? What would be the most meaningful for you, rather than this is what my MSW training told me that I had to do. This is what my employer tells me that I have to do. It might be, like you said, they might want to sit in front of a group of people and talk. It might be that they want to go to a sweat lodge. It might be that they want to go, as you were talking about earlier, and give testimony in a church. It might be any number of things that our communities have been doing for generations. Heck, we're still here. Yeah. So what I'm interested in is, how do we take from a respectful, honoring place, like you were saying, not cultural appropriation, but respectful, building on the strength, and build it into evidence-based practices that we know work, like a suicide safety plan. We know a suicide safety plan drops repeated suicide attempts by 50% in Veterans Affairs populations who go to the emergency room. We know this. So now, if we can step back and say, well, now, who was that research done with? Was it done with mostly white veterans? What might it look like if we were to do the same research with communities of color? And maybe it would be with communities of color that when we do that suicide prevention safety plan, part of it is the place that I go to get support when I'm in a tough spot might be that sweat lodge, or it might be that ballet folklorico group that I dance with, or it might be something else. But in order to know as a clinician, when I'm working cross-culturally with someone, I need to know a little bit about them and their community and what those community strengths are, like you were talking about.
And some of it's like educating, and books are helpful, and people can talk and talk to your colleagues and go to trainings and honor people's information, not that extractive. Like, I won't ask you about anything else. I'm just going to ask you about this thing over here. Because we know what you're doing when you're doing that. Like, oh, you can't talk about general stuff, but I'm going to come to you for the Black folks stuff, which, again, I might know the Black folks stuff, but I also know a lot of other stuff. So thank you very much. And so if you only come to me with Black folks stuff, I tell people, don't be, and excuse my language here, the shitty white ally in the realm of Benjamin Rush, who was the father of psychiatry. His little face is on the American Psychiatric Association. I think it was a Quaker, but and he was really about, like, he's kind of an abolitionist in his own way, but he had horrible ideas about Black people. And he was like, but I believe in, you shouldn't be slaves. I don't think you're equal, but you shouldn't be slaves. And it's like, Benjamin, I'm not really feeling you the full solidarity of that stuff. So don't be Benjamin Rush, okay? But the other part about is like it's an ongoing rebuilding of longstanding damaged trust. It's about and again, it's also what you do with this stuff. Because a lot of times when it's really about appropriations, it's like, you're not looking at the ways that I'm suffering today, not just my people suffered back then, but today, but you want to wear my regalia, you want and treat it as like not the sacredness or whatever that is, and to sort of come in and sort of communities and throw a little, in the 80s it was terrible. People would just throw up kente print left and right as if that was going to make Black people suddenly spontaneously heal. And and so it's like, don't do that, but also make sure. So to your point though, is here's a good thing that you do: create a fund where, and this is something an organization called Beam that I think YOLO YOLO is just like so off the chain incredible. And it's all this innovative stuff. And so it's like, one is expanding who's a healer who can offer mental health treatment, creating a base of practitioners beyond mental health practitioners, so somatic workers and massage therapists and all these kind of folks. And so that's coming up from within our own communities. And if there is funding for that stuff, if there's funding in all these communities for those kind of things to raise up, that's what makes the difference. I sit there, a friend of mine, Elijah Neely, who's done just really powerful work in terms of supporting trans community and trans kids, recently passed away. And I just he just devoted his entire life to trying to educate people so they wouldn't do harm to these children and these young people and these adults. And so but the thing is, who funds that stuff? We have to fund it in our own communities, but we also need people with big money to fund that, so we can, one is get the care to people right away, but also, and create our own organizations. And that's the something too, is that, and I have had points in my career, it's like, I can't do y'all anymore. I can't work in your organization. Like, my community is suffering. I'm going to go over here and do my community. And you need to respect people when they make that decision, because that does not come out of nowhere. It came because people had gotten so exhausted for, one is trying to care for our communities, deal with the straight racism that we were dealing on the daily basis. And all with the pressure of really trying to, fulfill our purpose and do work where in under-resourced places. Because if you're dealing with marginalized folks, you're dealing in under-resourced spaces anyway. So all of that is a sort of long answer is, one is, if you have access to money, get them to fund both programming, but also the evaluation. Because the other thing, how does something become evidence-based if you don't get money to fund it? If you don't drop money in that grant for evaluation, don't expect it to ever rise, promising practice, whatever. And then don't expect it to ram it through this sort of Eurocentric view of what evaluation looks like anyway. So there's all these different levels of where it gets shut down. We're like, we don't understand why you people don't do research. Well, because all the different hoops and the things that we have to do, it's like, by the time we get and fulfill all your things, our people are lying scattered in the streets anyway. So, I just think there's ways that people in the room that can direct funding. is whether you do a pilot project, make sure people have enough money, but also if in fact you then want it to be rise to evidence-based practice and you're going to create the standard, which is a whole nother piece of racist fantasy nonsense. Because as I said before, and let me just say, I got good grades in graduate school. I did struggle with statistics and that kind of stuff. And I'm not strong on the math tip. But, if you basically give someone $300,000 to run a program and you evaluate at that $300,000 level, then it's subtly approved as evidence-based, but you only give me $30,000 or even $100,000 to run that same program. I don't think it's the same program. I am not operating with the same resources. And when we don't talk about the mystery that is evidence-based practice with that kind of nonsense, we are perpetuating communities, vulnerable communities, not getting what they need and not having the practices that we have to go to save ourselves from the existing evidence-based practices that are not evidence-based, plus they're basically fund at a pittance, and then that practice never gets, fixed. I mean, I do aromatherapy sprays and I think they're very helpful to me. They're very helpful to my clients. I start making them for my clients. Then one client says like, I think I might buy some of this thing. It's like, oh, okay. Like I find that really helpful. And here, have some conscious grieving. And that really helped me. And because it made me like, whatever, like, and I don't care. My aromatherapy spray will never probably be considered evidence-based practice. And you can imagine how I don't care about that. And I actually have a name of a spray that would indicate I don't care about that. But,
But you do.
Yeah, I do. But part of it is like finding the ways and inviting people to know, like, what would be helpful. It would be this. Well, if I had like a safe place, and that, again, that's why I like, like the peer respite centers can be so helpful, is that there's people there that get what you're feeling. And sometimes you just need to be left the hell alone for a moment to get a quiet moment to yourself. And we are constantly bombarded, and so this crisis of people suddenly coming out of the woodworks for therapy, and not enough therapists who are safe, is that we're not prepared. If people decided that if every one of our educational programs to outreach and get people to come in, have capacity anyway. And that's with every warm body in the room. We're not talking about the people who just straight up are not safe. And I don't know about you, but I've sat in some training rooms where it's like, I just need to get this. I've tried a couple of times. That woman just said so many bad things. I don't even know where to start to basically help her frame this differently, because it's just bad. I need to get my 5 hours of stuff and get out of here without screaming at her. And we just need to do better. We need to do better. And sometimes we stand up. Sometimes we're like, let me get my 5.5 and get up out of here, because I don't think anybody is going to, like, basically they stopped talking to me after my second comment. So I saw at the break, it was like, oh, curse of death on her. And, but it's but to find spaces, I guess I want to say to everybody there, it's like, find the spaces with people. They're not co-signing. They're people that are challenging you. Mm-hmm. I just read something. I came late to knowing about Grace Lee Boggs, who was this incredible Chinese American Black liberation activist from Detroit. Detroit creates this incredible blends of amazing people that come together, and in her work and in her husband James Boggs' work, I mean, it's just that what she came to too, I mean, she just rigorous, like her stuff, her intellectually, some of it made my brain bleed because it was just so deep. But the other parts where I could meet, it's like love, loving the community, loving people. And also when I talk to people and read about people who were kind of mentored by her, they're like, oh, she was never easy. It was like, oh, she would really like make you have to break your argument down. So by the time you left her, you understood where you stood with your theory, or what your belief was, is that she was not going to let you be lazy about that. And so sometimes it's also you need the people that affirm you, that encourage you, but you also need the people who are going to challenge you, and make you get tighter with what you're doing. And you just need a place to breathe too. And I think that's the other part. And look at all the cool stuff. The cool stuff that's happening is really happening out there with activists. I mean, they're the ones that are like they're doing like a lot of innovative work, like YOLO and Beam and Adrienne Marie Brown's book. Although, I mean, I've seen people like, I don't think that's what I don't think emergent strategy means what you think it means, because I think you're using it to beat people up. And I do not believe that that was where she was going with it. So anyway, all the good stuff.
I just cannot thank you enough for the time that you've shared with us. And I'm going to have to extend as many invitations as you will possibly even allow in your inbox to come back, because this is just not even scratching the surface. It does remind me that we've repeatedly talked about how calling 911, having law enforcement as first responders to behavioral health crisis is lethal. It is lethal for communities of color. It is lethal for transgender people. We can keep police officers out of the role of de facto behavioral health crisis providers by not calling 911. And thankfully, there's 988 that's about to be rolled out across the country. This is an alternative to calling 911. Additionally, for people who are in California, you can go to the CARE website, and there's an asset map where you can look up the local crisis call lines, the local peer respite centers, the local pre-psychiatric stabilization units, mobile crisis units that are in your local community as alternatives to 911. So at the very basic level, not calling 911 unless there's an absolute reason to do so. And most of the time there's not. It's just, that's what most of us were trained to think about. Oh, someone says they're suicidal, call 911. And in fact, that's just not going to be the most helpful for people. And for many of the people in our community, it's lethal. So just if people can walk away with that, that's a huge anti-racism strategy to interrupt the crisis care continuum and justice diversion. I cannot thank you enough, Vanessa, for being here. And I know that so many people are going to be taking your work from this presentation and applying it to their local work. You mentioned several books and articles that you've written. I want to include those as links so people can check out your work if they are as inspired by you as I am. This is only the beginning. There's so much work that you've done for a while now that we can really get into. So thank you so much for your time, and look forward to being in community with you.
Absolutely. Absolutely. In community. Take care.
Thank you. Bye-bye.